Hello, hello. Good morning, everybody. How's the conference going for you all? Good, good, exciting. We're really excited to share what we've put together today. Just an overview of how technology and digital tools can be used to enhance mental health research. I want to get started by, jumping right in and introducing the panel. Today we have with us Dr. Fernandez, who will be discussing the Aspire study that looks into alcohol addiction and use specifically around the operation room, before and after the operation room, helping to manage how people use alcohol. Next, we will hear a little bit more from Daniel Wilson, who is addressing the intention behavior gap, how what we want to do may not align with the actual action that we set up to achieve our goals. Lastly, we'll hear from Fang, who will talk about the intern study that's looking at managing mood and depression for medical school residents. Without further ado, I think we will get started with Dr. Fernandez, who will share a little bit more about her research and some of the cool things she's been working on.
Hi, everyone. Excited to be here, and thanks for coming. I know you probably have some choices of symposium, so it's always good to have people in the audience. So really good to see everyone. And so I'm going to talk today about a research study that I worked with our industry partner, CareEvolution. It's the Aspire 2. The Aspire was our pilot. Now we're on to the second phase, so Aspire 2 study. And I'll be talking about a particular digital tool that we developed as part of this study that's called On Track. And the idea with this tool is that we're empowering people to self-manage their alcohol and other substance use using digital tools. And we use some theory-based and evidence-based strategies to engage people. So I'm a psychologist, and I studied health behavior change as part of my PhD, and also addiction. So I'm very interested in health psychology, decision-making. I've studied vaccination decision-making, but also decision-making around substance use. So very driven by some of those theories and trying to use some novel and different ways to engage people. And I have no conflict of interest. I do have funding to disclose, but no conflicts specifically. So as they just mentioned, my work is centered, this particular study is centered around the surgical episode of care. And I always like to give an overview of what alcohol and surgery have to do with each other, because not everybody knows this. Usually intuitively it makes sense once we start talking about it, but it's not something that's always on people's radar. So alcohol use is one of the top 10 surgical risk factors in terms of how common it is in our culture. It's defined in different studies, different ways, but generally more than 2 drinks a day is considered a high-risk behavior for surgery, in that it leads to surgical complications. Things like higher risk of bleeding episodes, cardiopulmonary complications, neurological complications, and this is across all types of surgeries. And it also can lead to alcohol withdrawal for people who are inpatient after their surgery. We've had people die from that at the hospital, actually, for undisclosed alcohol use. And alcohol withdrawal is the only withdrawal that can kill you, if you weren't aware of that, just a fun fact. Alcohol cessation, though, before surgery can improve surgical outcome. And so studies have looked at both trying to reduce and stop alcohol use before and then after surgery as a potential intervention. In the US, there's been really little work done in this space. There's a group in Denmark that has done most of the RCTs that have shown this. So I did a pilot study, and this is our fully powered randomized controlled trial. It is a SMART design. So for those of you who aren't aware, a SMART is a sequential multiple assignment randomized trial, which means, in very brief, that we randomize people in our study twice. And I will show you in the next slide what that actually looks like and how the digital tool fits in. But just a really brief trial overview. We're enrolling 440 people across 3 years. We're still in the first year, so I'm going to show you some early data from our digital tool. We have 2 treatments before surgery that people can be randomized to, either a virtual health coaching or usual care. And then they have surgery. We assess them again. We see if they responded. So were they abstinent for the month before and the month after surgery as we recommend? If not, they're non-responders. They're randomized to different treatments. If they're responders, they're randomized to different treatments, which I'll show you in a second. The post-op treatments are the virtual health coaching or on-track digital health tool, a combined condition where they get both, or usual care. And then our outcomes, which I won't present on today because the trial is ongoing, are alcohol reduction and surgical complications. And our aims are to evaluate the best pre-op treatment, the best post-op treatment, and you can also, in a SMART, look at the best adaptive intervention. So what's the best pathway that people can take? So this is a little bit busy, but just to really briefly, the R is randomize. So you can see when people enroll, at least a month before surgery, we randomize them to virtual coaching, usual care. They have their surgery, we assess them, then we re-randomize them if they're responders to do nothing. They responded, great, keep it up. Or we give them more virtual care to try to keep that going. Or for non-responders, we give them the on-track digital tool with or without the additional virtual coaching. Any questions? It's a little complicated. So just before I jump into what the tool is, and mostly what I'm going to be focusing on today is talking about the on-track digital tool. So that's where it fits in with the flow. Everyone in our study has risky alcohol use, so that's what they're enrolled on based on inclusion criteria. So we opted, even before the pandemic, to do a fully digital and virtual treatment, which the pandemic came and we were very lucky because we didn't have to stop our study. And that was for the pilot. So we did this because clinics for pre-op treatment are really numerous and dispersed. So there's so many different types of surgeries at a given health system, and they're spread across a region. So we can't actually have a health coach or an individual person in one place be able to access treatment and give treatment to people. We also found that both clinicians and patients were asking for a out-of-clinic, more flexible option to access care. Some patients might have liked to do it on the day of their visit, but it's really busy. And so if they can do it virtually on their own time, it's more feasible. And there's actually a program at University of Michigan called MShop that does this for incentive spirometer or to increase lung capacity, to increase physical activity, and to do other things. And they use this. It's a single treatment clinic, a person that you call, and they give you this treatment. So we were like, well, it's working for that, so we did it for alcohol also. You can access this from anywhere, and it's less burden on staff, which is a very real consideration for both healthcare and for researchers who have to pay for the staff. So this is on track. So our digital tool, and I'll walk you through what participation in it actually looks like. We developed it with our industry partner, CareEvolution, and it's a 28-day program where we use this idea that both just tracking your behavior, setting goals, and getting feedback is enough to potentially change behavior in a healthy direction. So has anyone ever done calorie tracking or steps tracking? And have you ever noticed that maybe you start walking a little more, or you maintain or reduce calories because you're just paying attention? So addiction, as you know, is very stigmatized, and people actually really like these kind of low-touch treatment options where it's very easy to make someone feel judged. Even when we try not to, we get a lot of feedback. We enroll people in our study and they say, why do you think I'm an alcoholic? That's what people say. And we're like, well, actually, we've never said that. But as soon as we're talking about alcohol, that's kind of a reaction that people have. And so we found people actually wanted these very kind of self-driven tools. People, when we did qualitative interviews, talked about wanting to have things like apps where they could access and track things. And a caveat is that These will likely help people with lower intensity alcohol problems. We have a lot of self-management tools for that. Often when addiction becomes very severe, you obviously need a lot more intensive services. But the majority of people in the US, believe it or not, change without treatment. Only about 10% of people get specialty care. So 90% of people are not. And they're still often changing by themselves. So there's a lot of room for this even within addiction, which we think of as a high needs specialty care situation. So an important thing about this that I'll talk about as well is that we use monetary and non-monetary incentives using strategies based out of the contingency management literature. Has anyone heard of contingency management? I see a few nods. So what contingency management is you are incentivizing a given behavior change. You're verifying a given behavior took place, and then you're often paying people. So it's actually one of the most empirically supported addiction treatments. Very low implementation because of clinic barriers and payer barriers, which actually there's been a lot of movement in that space recently. That's a topic for a different talk. But given the evidence base behind this, we integrated this method into our study as well. So when someone enrolls in the app, the first time they enroll, they set goals for their alcohol use. So what's their personal limit on a daily basis, their nicotine use, and their substance use. The first day they set goals, but they can change that goal anytime. They can also set a personal goal. I've read through what people have put in. It's things like drink a certain amount of water a day, take a walk every day, do my physical therapy. So they can just set a goal. It could be read a novel. It can be anything that's taking place on a daily basis. So this is just what the screen looks like that they get asked every day and the goal changing. Likewise, this is the nicotine use, and I don't have the slide, but for substance use, we have the same thing, and they can specify what substances they're using. So if they say yes, then they say what substance they used on a given day. And this isn't assessment data for our study. This is just intervention data and data collection. We'll look at it and we'll use it, but it's not our outcome data for our study. So after people log in and they answer questions, so they get asked about substance use, but they also get asked about pain, mood, and stress. And then they get to a dashboard. So their daily involvement is basically answer these 7 questions a day, and then go to the dashboard, and they've earned their reward. And I'll show you exactly what that monetary incentive is, but we also use non-monetary incentives. We use inspirational quotes, we use little celebrations, we use a lot of informational feedback. So you can see when they reach a goal, they get a green check for their personal goal, health, nicotine, substance use. And they get a little bit of information about their streak, how many days in a row they've logged in, as well as how much rewards they've earned. And you can see the rewards around the top. Those little bubbles are every time they hit $20, we send them a check or a gift card in the mail. So we didn't want to wait till the end. But we also weren't paying them through the app directly. So this was our system that we used to get people incremental funds as they went rather than waiting 28 days. And then they also have a tab called My Data, which shows their personalized feedback and display. So we have a screen for alcohol, nicotine, tobacco, where you can see that yellow line is the goal they've set, and they can see when they've exceeded their goal and when they've stayed below their goal. And you can look at this all in one screen. The idea that was very intentional so that you can actually see the patterns of the graphs and how your stress or your pain may correlate with your alcohol or substance use. And we have found that stress and pain are related to increased alcohol use. So on a day where stress and pain are high, alcohol use is higher. And then conversely, positive mood is also related to higher alcohol use, which I'm guessing is related to celebrations and things like that. And then in terms of our incentives, so the first time someone logs in and answers questions, they get $1. The next day they get $1.50. The next day they get $2. It doesn't go up forever. or we would be paying a lot. At $4, they max, and they stay at $4. However, if they miss a day, they go back to $1. So we explain this really clearly to people when they start. So we're incentivizing streaks. We want people to be doing this every day. So now I'm going to show you some of the data we've collected for the study. So we've enrolled 32 people in the app so far. We have about 75 in the trial, but it takes them a few months to get to the app phase because it's about a month after surgery. So the average age of people in the app who have enrolled and randomized to receive On Track are 47. A little heavier skewed towards female. We have a lot of gender-affirming surgeries in our study, so the gender breakdown is actually fairly even with male and female. We have, I think it's 3 transgender and 1 non-binary individual in the study as well. The ethnicity is largely non-Hispanic. We have 2 Hispanic individuals, predominantly white, and 4 Black individuals, which is fairly representative of Michigan medicine. And then of people who've completed the app, so only 19 people have done all 28 days. So I'm only going to show data for those individuals. So out of 28 days, the mean engagement is 26 days. So people have done it almost every day. We have 1 person who only did it 2 days, who's really throwing our mean off, but the median is 28. The average streak is 22.5 days. The cumulative total earnings, the average at $86, almost $89. The maximum is $101.50 because we didn't want a round number, apparently. And then most people access this via the app. There's a web option, and we do have some people use that. And I've noticed users who use the web also use the app. So clearly some people, for different reasons, maybe they're on different devices, have logged in different ways. So did people meet their goals? So, and when someone sets the goal, all we know is if they passed or not, they exceeded their goal or not. They might change the goal over time, and we don't have an indication of was it a healthy goal or not a healthy goal. All we know is did they exceed their limit. So for personal health goals was the lowest achievement at about 66%. Alcohol goal was about 80, which is pretty good, I think. Tobacco, for people who use tobacco, you may recall everyone's alcohol is chosen based on alcohol use, but they may or may not use tobacco or other substances. So we're presenting data only for those who have use. So tobacco is 89%, substance is 95. And in terms of the actual substance use, drinks a week is about 11 drinks a week on average. Nicotine is about 77 incidences, whether that's cigarettes, vaping, whatever method, and substances, which was cannabis exclusively so far, is about 11 times a week, 11.5 times a week on average. So, and we have looked at some correlations between some substances. As I said, we don't have outcome data to present, but we do hope we're going to keep collecting data and see obviously how this plays out in terms of how effective it is for helping people reduce or maintain reductions in alcohol use over time. And hopefully the hope is that we could implement this more broadly among surgical populations, although it's really not surgery specific in any of its tailoring, so it could be used very easily for people outside of the surgery space. And so that'll be the next step in this line of research, as well as we've had some conversations about potentially maybe integrating some other chronic health conditions into this and marrying it with some EHR data, but to be determined. So yeah, in summary, this is our data and success so far. I want to acknowledge and thank CareEvolution for their partnership in helping build the tool, my co-investigators and project staff, and that's it for me. Any questions at the end? Okay. Thank you.
Thank you. Yep. Thank you. We'll do all questions at the end and do kind of discussion too. But thank you so much, Anne. That was really fascinating and cool to see that there are already some results coming through about adherence and things like that. Next, we're going to move on to Daniel Wilson, like I mentioned, working on research around the intention behavior gap. Daniel wasn't able to join us today, but was kind enough to put together a video, a pre-recording of his slides so that we can all still learn about what he's been working on.
Hello, I'm Daniel Wilson, a PhD candidate at the University of Toronto. Sorry that I couldn't join in person, but I am happy to have a chance to talk to you about some work I'm doing for my dissertation. My work is focused on a macro level at trying to develop tools that might allow us to increase individual well-being. So if we want to improve well-being, where should we direct our efforts? Well, researchers have found that for those people who are fortunate enough to have their basic needs already met, above this certain baseline, that there exists three basic components of happiness. The first is a set point, which is genetically determined, and that explains about 50% of the variation in individual happiness. And this, of course, is not really something that can be altered, at least with current technology. And then you can see in violet, there's the current circumstances, which account for 10%. This could be things like your job, your partner, where you live, income level, and these things, they can be changed, but we find that improvements, though they lead to, in the moment happiness, that happiness kind of goes back to baseline fairly quickly through a process known as hedonic adaptation. So this leaves this last component, this intentional activity that accounts for 40% of the variation in individual happiness. What's notable and important about this is that research has shown that this segment of the donut, of the happiness donut, actually can be used to meaningfully and durably increase people's well-being. The question I guess that raises perhaps is, do we really want people accomplishing their intentions? What if their intentions are bad? Well, based on my lived experience, this doesn't tend to seem to be the case. And looking at some data, some classic New Year's Eve resolution data as a proxy for, the nation's goals, my intuition, seems to be largely confirmed. You can see that these goals, are not potentially surprising, but it's hard to imagine, things like managing your finances better and eating more healthfully and learning a new skill, that they wouldn't have benefits that would be conferred both on the person wanting to engage in those intentional activities and also, society at large. So the takeaway for me is that this is really good news. This is great news. It means that we don't have to change people's minds, something that's very hard to do. We just need to help them accomplish their pre-existing goals. And given that accomplishing intentional activity can make us happy and people have good intentions, this seems like the problem is kind of solving itself, right? Of course, it's not that simple. We have this little thing called the intention behavior gap. Intentions and actions are not always one and the same. In fact, our set of intentions tends to often have more elements than our set of accomplishments, which means that not only are we failing to accomplish our own goals, but we're failing to save for retirement, we're failing to exercise, we're failing to attend to our mental health, all these kind of real, failing to engage in environmentally friendly behavior. These are all like real tangible losses. And it also means that we're making ourselves unhappy. There's a lot of research that shows that simply failing to accomplish any goal, regardless of its content, leads to decreased well-being. So we have these real tangible losses, we have these well-being negative effects. The obvious thing to do is try to reduce this intention behavior gap and kind of help solve both of those issues. This is, while a good goal, of course, there are challenges. First of all, people are not all the same. The fact that people are different and means that they can also have different causes, different mechanisms behind their intention behavior misalignment. So if we want to help an individual close their intention behavior gap, it stands to reason that the intervention that we use should be matched to the mechanism that's causing their gap. We also, we likely don't need an intervention all the time. We've probably all had the experience, for a day or a week or a month where we felt like we're on the ball, we're achieving our potential, we're living in this low gap state. It's great. And then we also have experienced the flip side, times when we felt like we're having trouble staying on top of things, running behind, just having a hard time getting things done while we're in this high gap moment. And it's usually pretty unpleasant. So the goal is naturally to avoid these upticks that push us into a high gap state. And our aim with our research is to develop tools that can address each of these challenges. So in the first instance, we're looking at phenotyping, using cognitive and non-cognitive measures to try and understand, what someone's root cause of their attention behavior gap is. So if you're looking at 3 different people with equivalent gaps, we can determine perhaps that for the first person, their gap is mainly caused by a lack of self-control, while the second is, just poor planning, and the third tends to be set very ambitious goals. And so this can help us tailor more effective interventions that deal with the individual's needs. And these personalized interventions, should ideally be delivered at points in time when a subject is most at risk from most at risk to flip from a low gap to a high gap state. Moments when they're most likely to benefit from the support or strategy of the intervention being provided. So for the rest of this talk, I'm going to focus on this just-in-time delivery tool that we're attempting to develop. So just to step out a second, so our approach, is one that focuses largely on observation, and definitely inspired by Gordon Allport and his quote where he says, "Psychology needs to concern itself with life as it is lived." And I think this, this is 80 years ago, but the same thing remains true today. And the exciting thing is that, as time has passed, our ability to make observations has greatly increased, radically changed. Just as an analogy, we have a picture here of Galileo's telescope that he built in 1609, and 400 years later, we now have the Event Horizon Telescope, which provided the first images of a black hole just last year. And to make this discovery, it required a resolving power 3 million times greater than that of Galileo's telescope. And to put that in context, with the Event Horizon Telescope, you could theoretically sit in a cafe in New York and read a newspaper in Paris. That's how powerful it is. And there's been similar revolution in psychological sciences in terms of our own resolving power when it comes to accessing the lives and minds of subjects. Here we have a picture from World War I where we see people filling out pencil and paper surveys. It's a psychoneurotic inventory trying to assess recruits' susceptibility to shell shock. And you can almost sense, viscerally, the demand effect of these people kind of watching over their shoulders, sitting next to each other. And so, over time, we develop better tools. We've had phone surveys, online surveys, crowd surfing with platforms like Mechanical Turk and Prolific. But now I feel like we're really entering a new and really exciting phase where we are able to leverage the massive capabilities of smartphones and wearables to allow for unprecedented, access to subjects' behavior. And also this is maximizing ecological validity. We can do this in the field. And we can now gather observational data without really physically observing. So for our work, we leverage these new abilities to try and capture basically any data stream that we thought could conceivably contain useful signal in order to predict fluctuations in an individual's attention behavior gap state. What does that look like? I mean, we have everything from physical activity and sleep to social media usage, when and how much, to rate of speech, to sentiment analysis on all the text they typed, to surveys of daily affect and daily diaries with prospective and retrospective reports on time use, cognitive tasks aimed at testing, elements of executive function. So this is like a real kitchen sink approach. But we just couldn't have done this previously. And, we use an online platform that, kind of helps us gather all this stuff in one place. In our case, it was MyDataHelps. And with MyDataHelps, participants have this daily, their daily surveys go out to them each day. They complete these tasks and surveys, and all that data, along with all this passive data, is kind of aggregated in the secure servers at MyDataHelps, and then we're able to take it from there. And so then we take the data. We have our own machine learning models that are personalized to the individual, which we use to try and make predictions about the gap, and then use those predictions to see is this a meaningful way of providing an early warning system of sorts for fluctuations in the attention behavior gap, and then we can provide that alert and use that alert as kind of a signal to deliver their personalized intervention. So at least that's the plan, right? As the well-known wordsmith Mike Tyson pointed out, everyone has a plan until they get punched in the face. And for a researcher conducting expensive longitudinal data collection efforts, opening your data files and seeing something like this is our own face punch experience. And of course, this is an experience we're trying to avoid. And so we invested some time and effort into trying to make sure that our participants would diligently complete their 20 minutes of tasks and surveys each day over the course of the 12-week study. And this is a bit of an ask, right? I mean, already, but these are first-year undergraduates. They have a lot of changes in their lives. To have them remember to do something each day like this is not, it's not necessarily going to be top of mind. And so we use some of the tools that we're able to access through MyDataHelps, and one is the ability to create these views where you're able to put in your own tabs in the bottom of the app, and we created a dashboard through this views functionality, and developed basically our own standalone web app that was like pulling data from the servers and kind of giving subjects real-time access to their performance, their activity, and the amount of money that earned, and they can access that directly through the app. So in the earnings tab, we tracked which, based on subject feedback, was the most exciting tab. We tracked not just their earnings, but also let them know how close they were to getting a streak bonus for 7 consecutive days, how many entries they had in the weekly lottery where they could win a bunch of money and they would lose an entry each time they missed a day. And this was like something that, we're trying to counter this natural delay discounting tendency in a 12-week project, or 12-week project over the course of 3 months, to make the money that they're earning feel as salient as possible. And we also, had a number of other screens where we're tracking kind of like these different metrics, like an activity and performance and reward over time. Or with the reward screen, for example, we're showing like what you could possibly get if you had perfect adherence going forward. And then we had this comparison between you and the rest of the cohort. We didn't actually activate those screens because we were worried about adding another variable to our study. But we do think that could be another valuable way to promote adherence. And so, did it work? Well, for our first cohort, we actually didn't have, you can see their data here, the left side's cut off, but we have, you can kind of see the important information. We didn't have this information, this dashboard ready at the beginning. It kind of came online halfway through the time. And so we weren't able to kind of go through it, onboarding and stuff. And we were still like reasonably happy with our adherence. We had 25% of people that gave 77 days of data or more, which it's pretty good. And 50% had 38 days or more. But with the second cohort, when we actually had the dashboard up and working from the beginning and kind of like highlighted it during the onboarding process, we had drastically different numbers. You can see that 75% of our sample had 62 days or more, which we're delighted with. And kind of, and we even had like a huge number of people, in our opinion, that had 84 or 80 or more days. So just a quick orientation as to where the project is now. So we're deep in the data analysis process, and our initial findings have been pretty exciting. I would love to share them with you, but we don't really have time at this moment. But hopefully, coming soon to a conference and journal near you. Also, I just wanted to put out an open invitation to get in touch with me if you think that there might be some useful information in our data that could shed light on a question that you have, unrelated to our own questions. And because we just really do have an embarrassment of riches and when it comes to our data, and we'd love to see others leverage our collection efforts into their own findings. And we have like a number of collaborations already on the go. We'd love to have more. So if you want to get in touch about that or about anything else, please just send me an email. And finally, just a big thanks to my lab, led by Sandra Hutcherson, and the many people, I'm just listing a few here, who have been involved with this work and helped along the way. Thanks, and enjoy the rest of your conference.
Yeah, wow, that's pretty cool stuff, especially being able to see the transition and adherence between the non-visualization cohort to the visualization cohort with just return of information and some tracking. So that was pretty cool. Thank you, Daniel. I think you're listening online, so really appreciate it. Next, let's introduce you, Fang, who will be talking about the intern study, which addresses mental health for medical school residents. Thanks, Yu.
Hi, everyone. Thank you for coming. I'm Yu. I'm a research specialist working University of Michigan at Dr. Suzhang San's lab, which conducts the intern health study. Today, I'm just going to go over a little bit on what we have done with this, using the mobile data technology to apply in this mental health research. My speak will be first do an overview on the intern health study, what the study is about, and introduce a little bit about what we have done so far with all this data, what we have found, and then touch a little bit on the some new data types we have been collected with the Apple Sensor Kit. So what is about interns? The first year medical residents, they just graduated from medical school. They joined their residency with excitement, but then found out they are put in this stressful working environment with exceeding long work hours. They are sleep deprived. They have met a lot of situations at the hospitals. So their depression rate actually, as shown in this graph, at the baseline, before they enter internship, the proportion of depression is about below 5%, but then throughout the year, during intern year, and it's consistently around 25%. It's a huge increase, and and then depression is highly correlated with their medical performances, and it's also, I think, related to some attrition in their career. So it's really a pressing issue that needs to be addressed. And as well, this population, this group of people, they are young, healthy individuals being put into a stressful environment. At the same time, as a great stress model that to test under the stress what factors are associated with this development of depression. So this is our pipeline of enrollment and study each year. So each year this study actually has been going on since 2007 and actually accumulated over 26,000 subjects over the years. It covers all the specialties we can find, and it's conducted in around more than 400 institutions across the United States, and we have been, and then we started to pilot the wearable data collection actually since 2014 in University of Michigan, and started to collect the daily mood since then. And since 2017, we started to enlarge this range of the wearable data collection to all our participants. And so far, I think we have accumulated about over 8,000 subjects having this wearable data for a whole intern year. So on their match day is usually on March of each year, and then after that we get all the emails we can find and send them the invitations and the link to download the app, and then the MyDataHelps app. And then they will finish the baseline surveys, and then which can ask about their demographics, their PHQ-9 scores, represents the depressive symptoms, and then all the other psychological questions, and then they download the app, they get on board, connect their wearable devices. Initially, we were mostly doing with Fitbit, but gradually, as this intern said, we have Apple Watch, can we use that too? Then we add the compatibility to Apple Watches. So they either have their own wearable devices, or we provide the free watches to them as incentive. And recently, we also have added the compatibility to Garmin as well. And then they also provide salivary DNA, and then that's adds another dimension of their genetic data to our database. And since the internship starts in July, we keep following them from that July to the next June for the whole year. And on a quarterly basis, still give them follow-up surveys for PHQ-9 scores every 3 months, and some other questions like regarding their work hours and then life events and etc. But on a daily basis, we collect their wearable data of daily mood, sleep activities, and all sorts of things. This pipeline looks like, and then I wanted to just give a look like of our infrastructure of all the data collection. So interns, they provide wearable and phone sensor data that goes through all these fitness trackers database, and the survey and the mood data as well. And then they submit that through the app developed by CareEvolution, and they develop code for the MyDataHelps, and then all this data goes through the intern app. And we also, the MyDataHelps did the daily export to the UFM database, which is have a high secure level that is maintained by our IT group within the university. We also, this data, we are very open to data sharing, so not everybody in our collaborators have access to the database, so we also download it to the, also a high security level Dropbox, and do the analysis and sharing with our team. Another important component is that we also do the data feedback to the interns through the app, I think as the other studies have done, so that they can have a sense of what their data looks like and then getting more engaged. And this is a graph of like what data types we have been collected. So far, they have different layers, and in the surveys, we have there, as I said, like some demographics, PHQ-9, work-related factors, I think some personality measurements, their family, their medical history, so all sorts of things. On a daily basis of the wearables, have a daily mood, steps, sleep duration, resting heart rate, and activity levels, and so on, whichever is available through Fitbit and Apple Watch. And we also have more granular intraday wearable informations like heart rate, minute-by-minute heart rate, sleep schedule, and minute-by-minute sleep stages, and heart rate variabilities, and so on and so forth. The newer Apple Sensor Kit data also, we included some features I will introduce in detail later. So this is the some screenshots of the MyDataHelps apps we've been using, I think since 2021 cohort. So on the left side is the activity page. They just like have some recent activities of like how many days of data they have submitted so far. And then they have some messages that we send to them, and then they can check the message back again from this activity page. On the below, they have some tasks like connect their devices or finish the surveys. The middle graph is the interface. They submit their daily mood. They got a notification later, defaulted in 8 p.m. every day to ask about how was your mood today, ranking from lowest to 10, the highest. And they also have access to this dashboard on the right side just to show their graphs of their mood, sleep and steps over the past week or either past month or the whole year. And then they can get a sense of their own personal trend of this metrics looks like on a longitudinal basis. So this is like a quick overview of our studies and the settings. So with these data, as I said, we already have a bunch of data and have this been going on for I think 6-7 years. So we have done a bunch of analysis with this data. So the first layer of this analysis is about just look at what risk factors, what are the protective factors are associated with mood or depressive symptoms. Like what the most basic, like we found like the sleep duration and is affecting, like the last night's sleep duration is affecting the mood next day, and the mood also on the other side, like affecting the sleep on the next night as well, but not in a similar, in a smaller effect size. And we also found that not only the sleep duration itself, but also the consistency in your sleep duration and timing also plays a important factor in as that if you're more consistent in the sleep habit, the better mood you will have for the next day. We also have collaborators from math department that they developed algorithms to use minute-by-minute heart rate and to calculate the circadian phases of the interns. And based on that, we found that the timing of the mood submission, if it's a longer time from a week, then the lower mood it will be. There's definitely also, we found the relationship, like the higher step counts are related to better moods as well. And also the physical activity level is also, we use these causal inference methods to find out the physical activity level, higher activity level is related to like less depressive symptoms. So we have also done some fun projects that find that political events also relate to interns' mood. And on one particular day of 2016, that's the lowest mood we have ever seen among interns. So that's the first layer of like doing this risk factor analysis. But we also, on the second level, we wanted to do something about, are these a relationship like homogeneous among all people, or are there any like differences between people? So we used, because I mentioned that we have the DNA data collected, so we utilize this polygenic risk scores as one of the tools we have to see if there's any differences between people in terms of their responses to all this behavior. So the polygenic risk score, I don't know if any of you familiar with this concept. It's like, so you first have this GWAS analysis, genome-wide association analysis, to see any of the, so this top plot is the GWAS Manhattan plot. Each of the dots is one of the genetic variant. And then higher of them, that means the smaller of the p-value associated with the trait. So this graph is particularly about major depressive disorder, but you can do whatever trait you want, and as long as there are data. So this gives you a GWAS analysis give you each genetic variance effect size and p-values associated with the trait, and using those effect sizes, when we have our own subjects' genetic data, using those effect sizes as a weight and sum them all together to generate one single score for each of the participants as their polygenic risk score of, like, in this case, MDD. So usually the PRS, polygenic risk score, is in a normal distribution, and then there are low-risk people and high-risk people, as shown in this lower graph. So remember I mentioned a little bit about, like, we have found that the physical activity level is associated with depression, and higher activities associated with like lower depressive PHQ-9 scores. But then we did some subgroup analysis. We found that this association actually is more significant in this subjects with lower genetic risk of MDD. But in those these people with high genetic risk of MDD, the physical activities effect is almost no effects. So that probably give us some insights of, like, in the future, if you want to do any of the interventions, there might be some, you have to consider all these factors and whether to do the personalized intervention. On a side note, like, I'm not presenting in the slides here, but on a side note, like, we have done some other projects, like, to show that those high MDD-PRS people, they actually respond better to the social support than the low PRS people. So there are different schemes. On the third levels, we know all this knowledge, and then do we want to do, if we want to do some, aside from those dashboards, we also wanted to do some interventions, and it was made available by the apps. We are able to send messages to these interns. So we did like 2 randomized trials to just look at all these effects of interventions. One of them is just to deliver the messages. they are either generalized like tips, conveying those knowledges we have learned from our analysis or from some other analysis, encouraging them to like walk more or like having a better sleep habit or connect with our friends, family, etc. We also have these messages like embedding their own data, past data, and then based on like if their data if their daily step count is low, just giving them more encouraging messages and then that. And what we found that this messages effect, so they got the messages randomized on a daily basis, and then through the micro-randomized trial, we find that the effect of message is actually depending on their previous performance on this behavior. So if they're low in step counts or sleep, they actually respond better in these messages. If they're already doing pretty good, this message actually doing like deteriorating effects on them. So that's also give us some insights on that, like choosing when to deliver these messages based on their previous performance is pretty important. Another scheme we have used for the intervention is actually a little bit fun, just like considering all the, I don't know, like medical interns, they like to compete. So we do this competition kind of thing, just like with the unit, based on the unit of their residency programs. So for example, like you can see on the right side, like the Michigan Pediatrics and the NYU Anesthesiology is competing on sleep challenges on that for that week, and then they can see those on like real-time results from their app, and the middle graph kind of just show their past competition history with other programs. It's randomized every week whether or not to be in a competition for these programs, and also randomized on if they compete on steps counts or if they compete on the sleep duration. What we found in this trial is that I think the step counts competition has some, if they're in a competition, they will have, I think, average 250, 60 more steps every day. And then sleep competition also have some effects, but it's smaller. But all these effects kind of fade away after 6 to 8 weeks, I think. So it has some like fatigueness. So they have responses to this competition pretty well in the first few weeks, but then they got like a little bit tired over that. So that gives us some knowledge about like how long these interventions could work, and should we do more to just like get them more engaged and more responsive. So yeah, so this is some wrap up of the what we have done so far with all this data. And this cohort 2023, we are excited to include all these Apple sensor kit data in our collection as well, because we think some of the metrics maybe have potential in filling some of the gaps in our knowledge in studying this topic. But we were very careful because this seems to be a little bit like, some of the metrics seems to be a little bit sensitive, and we don't want them to be hurting our enrollment in overall. So we did some pilot testing in 2022 on our existing subjects that I think we randomized them into two groups. One of them just asking them for, I think, for those not so sensitive metrics, like ambient light or message or phone usage. And the other group was asked to enroll like for all the types available, like device usage. We think within our team, we think it might be a little bit more sensitive, and the speech. We like the red bar is the first group. We found that they are having a slightly higher like agreement rate to contribute the data. So eventually we decided to include ambient light, keyboard metrics, message usage, phone usage, and the visits, because we thought, even it's like a little bit sensitive, but we think it will be pretty useful. So we included that for 5 types in our 2023 enrollment. And to our surprise, we have pretty high enrollment in this sensor key data among our enrolled users. So we make it this as a separate, optional, so they don't have to contribute sensor key data if they as a must-have condition. So they're above 60, around 60%, 50% of the subjects enrolled are agreed to contribute the sensor key data, and then now give us more than 600 subjects contributing all these data types. And the lighter yellow bars are the 2 months. After 2 months, there's still a decent amount of subjects actually contributing all these data types. So we are very happy to see that. So I'm going to show a little bit exploration on these data types. We haven't done any serious analysis yet, but even for a quick glimpse, we found they're pretty interesting. The first one is the ambient light. They are in a very granular resolution. I think every second we even have to downsample it a little bit. But this graph shows the average luminance on an hour. So the x-axis is the day from April to September. The y-axis is on the hour, so from midnight to the next day's midnight. This is average over all subjects. But we can see that it's since their intern year started, their exposure to the light is drastically decreased. And there has some I think bars, I think that are weekends. I think that's also resonated with my personal experience with every time I go to a doctor's appointment, they ask me about what's the weather like outside. So I think they're very not exposed to lights. And there are studies showing that the light exposure is associated with the mood and the mental health. But I think most of the studies are being using just weather, whatever the weather institution has been providing us. But this just gives us real-time light exposure for each person. So that's pretty cool. And another cool thing about it is the visits data. So they're not really telling you the actual GPS location, but give us 3 metrics. I think one is the distance from the home label. I think that's showing on the upper graph. The middle graph is that they also, if the subjects label their work, place, and their home, and this is showing on the middle graph. And then there are also unique identifiers for each of the geolocation, although the GPS was not included, but they have a long string of identifiers, and then we can find their frequent visit locations marked similar as marked here. Why we're excited about this? Because on some of the analysis we have, I'm not sure, you're just using survey data, because in our survey we asked about their work hours, and also there's a huge amount of studies showing that the work hour is a main driver of the interns' depressive symptoms development. So every time we were asked, do you know their daily work shifts or the daily work schedules, and we don't have them. And because you don't want adding burden to ask interns or every day, what's your work schedule today? So far we only have every 3 months asking about their average work hours for the past week. But with this data, if appropriately cleaned and processed, and showing in the middle graph, for the first person, you can see most of the green represents the work and the red represents the home. And you can, in the first person, they have most of their work was on a daily basis, but there are a few night shifts. But for the second person, they have a lot of night shifts just by glancing at the figure. This also has some potential, so I'm very excited about this. And there's another, I think there's a lot of keyboard features, metrics provided by SensorKit, but what I'm showing here is just one example of like the typing speed. It's from our testers, but like there are different people have different like typing speed, but they definitely will have like personal within-person variabilities as well. And then we probably can like detect like fatigue or tiredness through this metrics. But yeah, that's another example of the what the potential are. So that wraps up like my presentation today, and then these are all our team members and collaborators from University of Michigan. A lot of them, yeah. So I want to thank them and also thank CareEvolution to provide this technical platform for us. And then we hope we can discuss more. Thank you.
Thank you so much, Yu, for showing us such an in-depth overview of all the cool things you've been working on. Just to tee it up real quick, we've heard a few people mention CareEvolution, MyDataHelps. Just really quickly, that's the like platform that's kind of powering each of these studies. At its core, it's just very much take data and act on the data, analyze the data, and make it available for exports. You can learn more at careevolution.com/MyDataHelps, but that's all I'm going to say about that. I think it'll be cool to start opening up the floor for any Q&A or discussions. I think we are asking that questions be asked in the mic up here so that it can be accessed on the recording. But if any of you have any, please feel free.
We haven't particularly looked at if there's any differences in demographics. Like even we have pretty homogeneous subjects, but they're different genders and different specialties. So there may be some differences, and I think that's a great idea, and we could look at them. So far, we have tried to provide as much data as possible, and then we also have like newsletters sent to them by email, and our incentive, a quarterly incentive, was based on their completion rate of their like wearable data and the surveys. So there are some things done, but we definitely welcome all these new ideas because there's a long way to go for this retention. But I don't know.
Unfortunately, I don't have as much to add as I would like, just because we're so early in the phase, and I'm hoping we have a bit of a ceiling effect in terms of engagement is the goal, which would mean that we'll have a little trouble parsing out some of those differences in engagement because we're incentivizing people to do it. But even your question actually raises some interesting thoughts of things that we could look at that I hadn't completely thought of. I do think giving people information is really incentivizing, so it'd be interesting to look at some of the things like Daniel's presentation, or Dr. Wilson, I believe was his last name, looking at some of those things because it was really fascinating how much that did increase engagement.
Sorry, you actually just answered my question. I was going to ask you about intention setting in people with high-risk alcohol and substance use and how that affects things. You know, if someone doesn't want to cut down or they don't see the harms in it, they enjoy it, then how do you reach those people?
Yeah, it's a great question. So, so that's a big struggle in the field. Substance use disorders in general, one of the characterizing aspects of that disorder is the ambivalence around change. And so one thing that I like about the on-track tool design is there isn't an intentionality on the part of the researcher to put, when we do our kind of more motivational interventions, we are pretty frank about, here's what healthy drinking looks like, and here, with permission, here's our thoughts and recommendations, where With On Track, we don't do that. It's really, what's your personal limit? So this idea that, alcohol use reduction may take place. We haven't, and we don't have the data yet to look at, mediators or moderators of how this type of treatment might impact people who have different motivation or intentions at baseline. But it would be something really interesting to look at when we get that.
Hi, thank you for your talks. They were really interesting. I have a question specifically about On Track and about its incentivization structure. So it seems that getting the monetary reward seems to be a very integral part of the incentive to use the app. But I assume that you would also like to scale it up, perhaps also outside of trials and studies at some point. Would you want to keep in the monetary reward? Because who's going to pay for that if you're going to deploy it at large scale?
That's a really important question. So I have a lot of thoughts about this. And so the short answer is yes, we would want this to be sustainable, and we would want eventually payers to pick it up. And so a few things come to mind. So surgery and anesthesia bring in the most healthcare dollars of almost any specialties, with a huge vested interest in improving outcomes from surgery being a cost-saving mechanism. So I do think if you could tie these treatments to improve and return on investment, $101.50 is like a penny to these kind of healthcare companies. So, a surgical complication can be like, $10,000, $20,000 of healthcare expenditures, which is where surgery makes money for institutions, but the complications lose money. So I do think there could be a vested interest in that if we can show that it's effective. The other case, so I'm working on a grant right now, it's due next week, that is using contingency management to try to treat co-occurring alcohol and opioid use disorder. And there's a digital tool and another platform that we're working with that has now gotten coverage from Medicaid for contingency management. Their Paratherapeutics was getting some support from some state governments. And the White House even came out saying that contingency management is a critical substance use disorder treatment strategy. So I think that traditionally there's been so many barriers to CM being paid for, but I think we're having like a bit of a watershed moment where that is changing, I'm hoping. So I think there's some ability, but I agree, if you just look at the landscape right now, you're like, who would pay for that? But I'm somewhat optimistic that if we could get data, that we could potentially make it happen.
Okay, cool. And then who decides who can actually use the app? Can you just freely download it?
So at this point, no. Okay. It's only in the research study. So you have CareEvolution and MyDataHelps is where people enrolled in the study can get to it, but because it's in a developmental testing phase, it's not openly accessible to anyone, although many of the other apps and different tools that they have are, but ours in particular, you need a code, you need an invite, you have to be a surgery patient enrolled in our study.
Yeah,
so yeah,
makes sense.
Hopefully someday.
Thank you.
I thought that was also a really interesting question, because something that we think about is also if you're able to increase adherence without monetary compensation at all. And so there are like many projects that we have where giving people the right set of information, Anna and I were talking about this before, but giving them the right information that allows them to draw the patterns between perhaps their sleep or their exercise and their mood and their state of being, like makes them excited, curious, it gives them the ability to experiment. And we're seeing that like by providing them the information, they are encouraged to use it. There's this piece of self-efficacy and also behavior change that's concurrent to help them kind of manage without any compensation.
I've noticed a lot of platforms that are starting to use the PHQ-9 or a lot of scales that may ask, sensitive questions over a long life of a patient being able to access that platform. What kind of safeguards do you have in place for when somebody does endorse a high level of suicide or something that would require really acute intervention?
So I think we're research studies, so don't directly do this acute intervention, but we did provide all this like information, like seeking for help. I think in our enrollment page and then in some information page as well. So we provide like the informations.
Yeah, so we have that on our study as well. So I'm a licensed clinical psychologist, so we have staff who are licensed to deal with that when it comes up. But in a digital space where in real time you may not be realizing it about it, we're pretty careful with what we ask. So we don't ask about suicidality in our online assessments and digital tools for that exact reason. We're not a suicide study, in which case you may want to, but in our case, we don't want that to live in a place where we're not looking at it and can't act on it. So if it comes up in virtual health coaching, we can act on it, but in that case we can't. So we're really careful about when we put those questions in and the ways that people can communicate information to us digitally so that they can't tell us things that we can't access in real time that we need to act on. And we also screen people out who have had severe alcohol withdrawal, because of concerns about if someone could have, it's a potentially fatal condition or, is medically managed. So we screen people out for that at baseline. And we don't for suicidality, but some studies do or don't, depending on the risk and what they can handle.
Really fantastic work. Thank you all for being here. My question is really more about, as we think about the outcomes, and we have a lot of passive sensing data and questions that we're asking patients and individuals, thinking about also their engagement within their own mental health journey and the data that is being presented back to them. Do you notice any correlation between the outcomes that individuals see with engaging in the apps that you generate to see like, oh, they're spending a lot of time in the app looking at what's happening. We see them having better outcomes. We can predict that early.
We actually wanted them to, I think the time spent on the app is not really a metric we're looking for, because we wanted them to use this, but not to add in more burdens to the interns because they're super busy. I think we have done those, like a couple of that interventions that just see. We also, I think from those trials, we did try to see if these interventions help to increase the engagement, but I don't think we found too significant effects with these interventions. Do you want to add anything?
We just don't have the data to look at yet, but we'll look at some data probably towards the end to see how much time, but it's a good question.
Sounds good. Thank you.
Thank you guys for the interesting talks. A quick question on a topic like contingency management and compliance. Have you guys looked into differential effects of different reinforcement schedules in terms of what's most effective? I mean, I'm just remember from like college, like psychology classes, it seems like a variable ratio, like reinforcement schedule. It's like similar to like what makes people addicted to gambling is most effective. I was wondering if those concepts could be applied in terms of increasing compliance to these type of questions that are being asked.
Yeah, it's a really good point. So we didn't in our study, but I agree. I know that literature a little bit, and I do think variable reinforcement incentive schedules could be effective. It's not something we applied here, but I know in some other studies that in some other CM digital tools that they have done that. So we opted for a little bit more of a linear one with some resets as our options, but I think there's a lot of really different and strong ways that you can do that can reinforce in different ways where you might not get the same exact reward every time, or there's a lottery system. So we didn't do it here, but I think your point is well taken. It's something that can be very effective too.
Thank you.
don't mind, I actually have, oh, go ahead. Go ahead. No, please.
Mine's just super quick. I feel like everyone's question, we have a lot around like engagement and what's been working. And so while I realize some of that data is still forthcoming, I'm just curious in these groups that you know, whether the clinician interns or, you know, in the patients, have there just been any like candid feedback that they've noticed of what they liked about, you know, seeing these apps, what they didn't? Was it the gamification? Like, was there just sort of any comments that they had about it?
Yeah, I can touch on that really quick and then hand it off. So we've had people, some of the people are in virtual coaching and in on-track. So the candid feedback we've had so far has been when they're in their sessions, they've talked about it and said, where can I get this when the study's over? We've had people ask and say they wanted to keep it going. And we've also had at least one or two people who just didn't want to do it. So there has been both positive and negative. Some people, despite the fact, we had one person who basically, I think their point was like, I don't want to set a limit for, like, why are you putting that on me? Where it just felt, even while we were trying to be as least judgy and stigmatizing as possible, they just found the fact that we were asking them to set, we use the word goal, we don't even necessarily use the word limit, but just the language and just the fact that it was focused on that felt like something they weren't interested in. So we've had it on both sides. But we'll do exit interviews at the end, but they have to finish the whole trial, which is 12 months. So we'll hopefully have more anecdotes later.
Yeah, I think I wanted to agree on ends that like there are like definitely differences among all different subjects, and then we have like very star users that just like wear the Fitbit for the whole year, and then even sometimes the Fitbit bands broke frequently, then they just ask for replacement and then keep wearing them. And we even have some subjects emailing us saying that during that competition scheme that their program, I don't know, won for several times, and they even had an ice cream party. Like they were really excited about those. So that's some like positive feedback we have been getting. But I agree with Anne that maybe in the future, just incorporating all this like systematic feedback scheme structure, just to get some sense of like overall what is most popular, what is least favorite, so then we can get a better idea of in future. Yeah, thank you.
Cool. I might throw one question out there a little bit around kind of more the adoption of digital and the process of doing that and implementing. And I think there can be a lot of kind of concern or hesitance with adoption around, especially I don't know. Maybe can you just touch a little bit on some of those concerns or excitement and how that went for you, and maybe you even as you've had multiple kind of years of the intern study, how your appetite for adopting these technologies has changed over time.
I think we are generally, like our team is generally like very excited about these new technologies, and I think our participants, because they are like young, smart interns, they are very, I would say very adaptive to this technology base. And like what I presented for the sensor kit data, we did not expect that high enrollment rate. Even they are like, in general population, we may think that they're a little bit intrusive or like on the privacy or anything. But in our population, we were very excited to see that how they embrace this new technology. And then, I think a lot of our participants, they already have their fitness trackers. And then that's kind of the reason why we, aside from Fitbit, gradually adding Apple Watch and Garmin's, because our participants just ask like, I just already have this Garmin tracker. Can I just use it in the study? I don't want to change my tracker. I don't, because I'm already used to the tracker. So I can't speak for the general population, but I think for our study, we were very fortunate to have these great participants. But definitely like, I will acknowledge that definitely will be variations among subjects, and then resonating with the last question, I think it will be nice to have a better sense of like who are more willing to adopting and who are not, and then be careful about all these bias might be generated through these differences, and how to make this more democratic, and then be benefit for all people, but not just those ones who are willing to have the technology. Yes, and then I wanted to say a little bit about, because some of the studies just like wanting to describe the interns like about how they are doing nowadays, and then a lot of questions we were asked about is like the representativeness. Our samples, can they represent all the interns across country? So I think this should be considered, that these differences and challenges. Yeah.
I think that kind of wraps it up on the time for us today, but thank you all for joining. Laura and the other panelists will be kind of around for questions if you have any, and looking forward to it. Thank you.